So good evening, everyone. Good evening, respected faculty and examiners. I will be doing a case presentation. So presenting the case of a 53-year-old male who's a resident of Haridwar, assistant engineer in Uttarakhand Jal Board by occupation. He presented to us with the complaint of chief complaints of lesion over left side of the tongue for 5 months. These are the clinical photographs. Now, a patient presented with a complaint of a lesion over the left side of the tongue, which he noticed 5 months back, which rapidly progressed from a small size to the current size. It was associated with pain over the left side of the mouth. The pain was intermittent in nature. It was burning sensation type and present mainly on touching or when the food used to touch over the ulcer, and but it did not disturb his sleep or daily activities. It was associated with excessive salivation, difficulty in chewing from left side of the mouth and swallowing. It was associated with a history of sharp tooth in lower left two molar, which used to impinge over the area of the lesion. He also has told the history of loosening of tooth, which was present. So these are the relevant negative histories which was asked from the patient, that there was no history of bleeding from the wound, no history of foul smelling from the mouth, no history of any hoarseness of voice or speech. There was no any associated history of changing taste, numbness or paresthesia around the lips, no history of foul smelling from the mouth, no history of any eating spicy food or any artificial dentures. There was no associated history of any cough, hemoptysis or chest pain, any bony pain. There was no history of any loss of appetite or weight loss. And he did not give any history of similar lesions in the past or any enlarged swelling over the neck area. He's a diabetic on regular oral hypoglycemic drugs. He has a history of chest tuberculosis 12 years back, for which he took 6 months of ATT. He has also given a history of taking a biopsy from the lesion 12 days back from a private hospital. There was no history of any other surgeries in the past. He used to chew tobacco or Kenny specifically for 20 years, and he also has a history of smoking tobacco, smoking BD for 20 years, but he has left it 4 years back, so around 10 pack years. He also has a history of alcohol consumption once every month for 20 years, around less than 200 ml, which stopped 4 years back. There's no history of any sexually transmitted disease. Bowel and bladder habits were normal, and he takes a mixed diet. There was no significant history of any oral malignancy, but his father had died from lung cancer 12 years back. To summarize my history, a 53-year-old male with a rapidly progressing ulceroproliferative growth over the left side of the tongue with a history of chewing tobacco, smoking and alcohol consumption, likely malignant in origin. In general physical examination, patient was conscious, oriented to time, place and person, sitting comfortably on bed and cooperative. He is a moderately built with a height of 1.72 meters and a weight of 60 kgs. The body mass index of the patient is 20.33 and ECOG score is 1. He is afebrile to touch. The blood pressure is 135 by 88 millimeters of mercury, taken in right forearm in sitting position. The pulse rate is 88 per minute, regular, good volume, taken in right forearm in a sitting position with no radial delay. The respiratory rate is 18 per minute, regular, with equal rise in chest. The saturation taken from a SpO2 probe is 100% on room. There's no pallor, icterus, cyanosis or edema. Cervical lymphadenopathy is present, for which detail I'll tell further in my examination, and systemic examination is normal. Now, coming on to a local examination, there was an ulceroproliferative growth present over the lateral surface of the tongue. The dimension of the growth was 5 into 3 centimeter, and ulcer present posteriorly, 3 into 2 centimeter, with the 1 centimeter duration progressing to the floor of the mouth. Now, on extraoral examination, on inspection of head and neck, there was no swelling as such, no ulcer visible from the outside. The mouth opening was 3 finger breadths or 4.5 centimeter. Poor oral hygiene was present, dental caries was present, and teeth were stained with tobacco. The dentition was 2111 in the upper alveolar region and 2111 in lower alveolar region. The tongue protruding and mobility was present, but it was a little restricted over the left side of the tongue. There was a single lump present over the left side of the tongue, extending from the tip of the tongue till anterior tonsillar pillar anteroposteriorly, and from mediolaterally it was crossing the midline medially, and laterally it was going onto the floor of the mouth. It appears on inspection to be a size of 5 into 3 centimeter, horizontally oval in shape, reddish in color, and appear to have defined edges. The ulcer present over the posterior aspect of the lump was present behind the growth with an intervening normal mucosa. The size of the lump was appeared to be 3 into 2 centimeter, again oval in shape with the rolled out edges. The floor appeared to be erythematous. There was no clots present, no pus discharge which was visible on the floor. The ulcer appeared to extend till the anterior tonsillar pillar posteriorly and appears to involve the left side of the floor of the mouth. It was close, the margins, the ulcer appeared to be close to retromolar trigon. The rest of the oral cavity appeared to be normal with no whitish, yellowish or reddish patch over the buccal mucosa, tongue, palate or lip or floor of the mouth. Now, on palpation, the inspectory findings were confirmed with the normal extraoral examination. The lump or the growth appeared to be non-tender. There was no local rise of temperature. It was firm in consistency. The edges were defined. The lump was free from the floor of the mouth and was extending laterally, anterior half and anterior surface was crossing the midline. The tip was crossing the midline. Now, on palpation of the ulcer size was 3 into 2 centimeter, present over the lateral surface of posterior aspect of the visible tongue, extending from lateral surface of the tongue to floor of the mouth without involving the gingivo-buccal sulcus. The induration was present overlying the floor of the mouth till 1 centimeter from the ulceroproliferative growth, and it appeared to be on palpation it was close to the retromolar trigon, but the retromolar trigon was free. The edges was rolled out, and it did not the floor did not bleed on touch, and the ulcer base was non-mobile. There were no other lumps, ulcers or induration palpable in the oral cavity. The bimanual examination was normal. On examination of neck, a single 1 into 1 centimeter firm, mobile, rounded lymph node was palpable over the right side of the neck at level 1B. The systemic examination was grossly normal. On examination of the possible donor side, the bilateral upper limbs were normal. There were no visible scars. Bilateral radial and ulnar artery were palpable. Allen test was run on both the upper limbs and it was negative. Bilateral lower limb, in bilateral lower limb, bilateral thighs, there was no scarring present. Anterior chest was normal. No deformities, scars or sinuses over the chest was present. So my clinical diagnosis is a 53-year-old male with ulceroproliferative growth over the left side of the tongue, likely to be malignant, most likely squamous cell carcinoma. Clinically CT4A and 2C. The M0 can only be confirmed after the metastatic workup, and the final staging of the malignancy can be done only after the MRI CT findings. So I would like to confirm my diagnosis with further investigations. I would like to confirm my diagnosis of malignancy with the punch biopsy from the most protruded part of the growth, which does not involve any necrotic or a slough part. I would like to do an indirect laryngoscopy to visualize the base of the tongue, and then routine blood investigations for PSC workup, an MRI face, an NCCT head and neck, and a CT thorax. Now my treatment would include a wide excision with 1 centimeter margin with bilateral modified radical neck dissection, uh, plus or minus marginal mandibulectomy based on the CT or CT findings of involvement of mandible, and with a free flap reconstruction. My reconstructive plan will be based on MRI CT finding, which will proceed with the resection. Since it is difficult to estimate the defect based on palpation findings only, we would wait for the final defect to be formed after resection done by a surgical oncology team. And if the 50% or less than 50% of the tongue will be removed, we would like to go ahead with the free radial artery forearm flap. And if the tooth if around 2/3 of the tongue is resected, we would like to go for a free anterolateral thigh flap. Now this is a growth of 5 into 3 centimeter with the ulcer of 3 into 2 centimeter, and we will include the 1 centimeter induration also as well. So our final defect will be 8 into 5 probable defect will be 8 into 5 centimeter with the 1 centimeter of induration. So we will make a template of around 10 into 7 centimeter.
Just a minute. Can you show the defect again?
Yes.
I'm Dr. Vinay. So here you said that you will probably have a defect of a hemiglossectomy, right?
Yes, sir.
So, but what I can see from the figure, I mean from this photograph, is that the defect is more on the tip of the tongue and not on one side of the tongue. Is it on the lateral aspect? It seems to be more on the tip and the, whether is it dorsum or ventral aspect of tongue, something like that, no?
Yes, sir. So majorly the growth and the ulcer is on the lateral surface of the tongue, and it is involving the half of the dorsum. But at the tip, as you can see, it is crossing a little part of the midline. So it is not exactly
So
half of the
what
tongue.
you mean to say is that your defect will not be, see, in tongue point number 1, it is not a hemigloss or a total gloss. It is actually known as a wide local excision, correct? So now if you
Yes.
will go wide local excision according to this type of defect, which you say is so close on one side, is also crossing on to the other side, then the defect that you will have will be more like a anterior 1/3 or anterior 2/3 of the tongue that will go. It will not be a classical hemigloss defect. A hemigloss defect will be when you have one half of the tongue which remains and other half of the tongue that goes. So in tongue lesions, it is also very important to see whether you have the floor of the mouth that will go or not. So what is
Yes.
your comment upon the floor of mouth?
Sir, the ulcer proliferative growth is majorly not involving the floor of the mouth, but a
No, but you
little
said that it
induration
is
is
very
present.
close to the gingiva.
Sorry, sir.
Is it close to the gingiva?
Sir, yes, sir. It is close to the
So if
gingiva
it is
buccal, sir.
close to the gingiva, that means it has tracked all the soft tissue and is almost touching the mandible. So when you will clear the disease from the mandible,
Yes, sir.
naturally your floor of mouth will get opened,
Okay, sir.
isn't it?
Yes.
See what boundaries you take for when you are so close to the mandible. Either there will be periosteal stripping. If it
Yes,
is
sir.
not touching the mandible, if it is touching the mandible, then there will be either a marginal mandibulectomy or maybe a segmental. If the
Yes.
bone, if it's very close to the bone, they will have to cut the bone as well, right? So
Yes,
in
sir.
this, the defect which you are assessing will not be a hemiglossectomy defect. I agree with you that it is not possible for us to just comment upon it without anything, but what I can understand that it will be more like a anterior 2/3 with some amount of floor, and it will be quite a complex defect. So in such defects, it is a little difficult to reconstruct with a. Uh, you'll have to take a call depending upon how thick the thigh is and how thick the radial artery forearm flap is, but it is going to be slightly tricky.
Yes, sir. So we would like to first ask the patient to undergo a MRI phase to see the extent of involvement and depth of invasion, and based on that, we will come to a final conclusion.
Okay, fine.
So I would like to end my presentation on the template drawn for radial artery forearm flap, which will be 10 into 7 centimeter. But of course, our plan of reconstruction will change based on the defect which will be created by the oncological team. Thank you.
Taruna,
Yes, ma'am.
uh, the actual including the is on both sides there is induration of 1 centimeter.
Hello.
The induration is the induration is all 1 centimeter.
Yes, ma'am. Induration is 1 centimeter towards the floor of the mouth, ma'am.
Only floor, not in all other three surfaces
No, ma'am.
borders.
Towards the dorsum of the surface and the tip, it is very defined, and the induration is not present there.
Posteriorly, anteriorly also there is no induration.
Anteriorly, ma'am, there is no induration. Posteriorly, I was able to palpate till the tonsillar fossa. There appeared to be no induration.
If it is induration is there, you have to measure your margin of 1 centimeter from the induration. So your defect will be more than what you are estimating. Okay.
Yes,
So
ma'am.
10 centimeter as far as you are telling the swelling and the ulcer, including the injury, isn't it?
Yes, ma'am. So
So if
combining.
1 centimeter margin on both sides, it will be 12 centimeters in length and almost 9 or 10 centimeters on width also, or 8 centimeters. Okay, you should not take what flap.
Okay, ma'am.
8 plus 2 plus 8 plus 2, 10, and 5 plus 1, 6, and
7.
2 more centimeters. It.
Yes.
Uh, so you wanted to do arterial mandibulectomy?
Ma'am, first we'll go for a CT, and then where we'll see whether a cortical erosion is present or not. And if there is a cortical erosion, we will go ahead with the periosteal stripping or marginal mandibulectomy to clear off the margins. Hello.
Anything else? Dr. Vishal, Dr. Vinay?
No, I think it was a short case. It was a short case, so we can just shift on to the long case.
Just one question I will ask. So just one question.
Yes.
After that, we'll show. So tell me, you have told about a free flap. What are the pedicled options you will, if suppose your flap fails, what is your fallback option?
Sir, the pedicled option which we can think of can be submental flap.
No,
Or
submental flap will not be possible as a salvage option. And you know why?
Size of
Because
the flap.
the size of the flap, yes. And also, once the neck dissection in tongue, usually extensive neck dissections are required. And if neck dissections are done, your radial artery will generally be fired and you will not be able to raise a submental flap. So as a salvage option, very rarely you will ever have. But others, yes, you can think of. What else you said?
Sir, for a pedicle option, we can go ahead with the deltopectoral flap.
Deltopectoral flap for tongue reconstruction.
Uh,
Whom have you seen doing deltopectoral flap for tongue reconstruction? Tongue, I don't think anybody does. I'm not sure, but it has. Have you seen it being done?
no, sir, I've not seen it.
No, so don't speak out deltopectoral flap. It is not a. It will be very difficult to get a deltopectoral flap for this purpose. Uh, you can base on pectoralis major flap. A
Pectoralis
major flap paddle if the defect is large and without skin paddle if the defect is small. If a defect is small, your only intention is to seal off the neck from the oral cavity. So even if you have a muscle flap that you can stuff below, then also it will, I mean, that is the last resort you have to block the secretions from coming into the neck, because that risks a blowout of the vessels in the neck, right? So Peckley's major is the most commonly used flap. Does the Peckley's flap? No. Okay, and submental also is not an option usually. Okay.
Thank you.
Dr. Anand can start his next presentation.
Sir, Dr. Anand's presentation is not showing on his laptop, so I'll be starting here.
Taruna, it's
Okay.
you said the what is the approach incision?
Hello.
You told there is a one lymph node on the right side, isn't it? Your lesion is on left side. There is a
Yes.
lymph node on the right.
Yes, ma'am. So,
And how, what incision will be given, and what type of questions you will ask?
ma'am, we'll give a visor incision and we'll do a bilateral modified radical neck dissection from level 1 to 5 for this case.
Both sides?
Both sides, ma'am. Both sides will do neck dissection. Since it is a contralateral side, so the disease has progressed to a contralateral side, we'll go ahead with the bilateral neck dissection.
Clinically, there are no lymph nodes in the left side.
No, ma'am. Clinically, no nodes were palpable on the left side of the neck.
Key findings, you are not aware of this CT finding. Will you do the triple endoscopy?
Ma'am, triple endoscopy we usually do if we are looking for an occult primary, or whether if we want to see whether if the base of tongue or the piriform fossa or the base of base of the tonsils is involved or not.
Not needed in oral cavity. Or do the triple endoscopy. Will you do only for occult primary? What for you?
We can do we should do in
Yes.
oral cavity malignancy to see for any synchronous lesions in the
Yes. Yes,
oral
isn't it?
cavity. Yes, ma'am.
Okay. You didn't mention, you have to. Okay.
Yes, ma'am. Thank you, ma'am.
Just I'm asking few questions before. Sharika, you shared the case presentation.
Yes, ma'am. Taruna said she'll put it in her laptop. Taruna, you can unshare this one and you can put Anand's presentation on yours then.
Yes, in a minute I'll start the presentation.
So for the students, sir, Dr. Vinay, Professor Vinay, so what will be your option in this patient, sir?
Good evening, respected teachers and dear colleagues. Am I audible, sir?
Yeah, please continue. Please continue.
Good evening, respected teachers and dear colleagues. Today I will be presenting the case of carcinoma oral cavity, that is carcinoma buccal mucosa. I am presenting a case of 31-year-old male patient who is a daily wage laborer by occupation residing at Muzaffarnagar, Uttar Pradesh. Came with the chief complaint of ulcer left inner cheek since 6 months.
Your PPT is not visible.
Anand,
Okay,
your PPT.
Yeah.
Taruna, please.
Yes, sir.
Just
So now is it visible?
Yeah,
Yeah, it's visible.
it is there. Okay, Anand, you
yes,
proceed.
just a second, ma'am. Now it's visible, no, ma'am?
Yes,
Yeah, it's
yes.
good. Now,
Yeah.
say
I'm presenting a case of 31-year-old male patient who is daily wage laborer by occupation, residing at Muzaffarnagar, Uttar Pradesh, came with chief complaint of ulcer over the left inner cheek since 6 months. History of presenting illness. The patient was apparently all right 6 months back when he presented. Then he presented with ulcer over the left inner cheek, which was of small size initially and gradually progressed to the current size. The ulcer is associated with pain over the lesion, which is of pricking type and aggravated by talking and chewing and relieved by taking medications. There is no radiation of pain and it affects the daily routine life of the patient and disturbs the sleep. There is a history of decrease in mouth opening. There is no history of bleeding from ulcer. There is no history of drooling of saliva or excessive salivation. There is no history of foul smell from the mouth. There is no history of change in speech or hoarseness of voice. There is no history of numbness or paresthesia around the lip. There is no history of trauma due to sharp tooth. No history of cough, hemoptysis, or chest pain. No history of bony pain. No history of weight loss or loss of appetite. And there was a history of similar lesion in the oral cavity 1 year back, for which over the inner aspect of left cheek 1 year back, for which wide local excision with split thickness skin grafting was done at some other hospital at Aligarh in October 2021. However, patient did not receive any adjuvant treatment for the same previously. Now patient has developed the ulcer at the same site 6 months ago. There is no history of diabetes, hypertension, asthma, ischemic heart disease or tuberculosis. There is no history of any other surgeries in the past. Personal history, there is no history of tobacco chewing. Patient is a smoker. He's smoked BD, one packet of BD per day for last 12 years, and he has stopped 1 year back. There is a history of alcohol consumption, 180 ml per day for last 10 years, and he has stopped 1 year ago. There is no history of sexually transmitted diseases. Bowel bladder habit is normal, and he is mixed by diet. Family history, there is no history of similar complaints in the family. On general examination, patient is conscious, cooperative, and well-oriented, time-patient person. Body mass index is 24.62 kilogram per meter square. Karnofsky performance score is 80. Is afebrile on touch. Pulse is 84 beats per minute. Respiratory rate is 16 per minute. Blood pressure is 124 by 84 millimeter of mercury taken in right arm supine position. There is no pallor, icterus, edema, cyanosis, clubbing, and generalized lymphadenopathy. Cervical lymphadenopathy is present, which will be discussed in the local examination. In local examination, on inspection, on extraoral inspection of head and neck, there was a diffuse swelling over left cheek of size around 6 by 5 centimeter, extending into the left submandibular region. The swelling is extending approximately 2 centimeter from oral commissure, 5 centimeter from left tragus, and around 3.5 centimeter 3.5 centimeter below the inferior border of the mandible. The surface over the swelling appears smooth. There is no redness or pus discharge from the swelling. There is no scar or sinuses in the head and neck. Mouth opening is reduced, that is around 2.5 centimeter. Intraoral examination, a single ulcer of a size around 5 by 4 centimeter is present on left buccal mucosa, involving the lower gingivobuccal sulcus, which is extending from first lower premolar anteriorly to third lower molar posteriorly, from lower gingivobuccal sulcus inferiorly up to 0.5 centimeter away from the upper gingivobuccal sulcus superiorly. The ulcer has everted edges. Floor contains pale granulation tissue with whitish patch in the center. There is no bleeding or discharge from the ulcer. There is no leukoplakia or erythroplakia seen in the floor of mouth, tongue, palate, pharynx, or lip. There is no missing teeth. Tooth caries is present from left lower third molar to left lower canine. Occlusion is normal. Tongue mobility is normal. Now, inspector findings were confirmed on palpation. On extraoral examination, the swelling is non-tender, hard in consistency, and fixed to the underlying mandible. The skin over the swelling is not pinchable, and induration of approximately 5 mm is present all around the swelling. On intraoral examination, a single ulcer of 5 by 4 centimeters present on left buccal mucosa involving the lower GB sulcus, which is extending up from first lower premolar to third lower molar posteriorly, and from lower GB sulcus inferiorly up to around 5.5 centimeter away from the upper gingival sulcus superiorly. The ulcer does not bleed on touch. The local temperature is not raised. The ulcer is non-tender and hard in consistency. Margins are indurated of approximate 5 mm all around the ulcer. Induration is also present in the retromolar trigon. Upper GB sulcus is free. However, the ulcer is 0.5 centimeter away from the left upper GB sulcus. On bimanual palpation, ulcer was abutting the body of mandible at the lower GB sulcus. The inter-incisor distance is 2.5 centimeter. There are no other synchronous lesion, leukoplakia, erythroplakia, or fibrosis over the floor of mouth, tongue, palate, pharynx, or lip, and left oral commissure is free. Examination of neck. A single lymph node of size around 3 by 3 centimeters present in left submandibular region, which is non-tender, fixed to the body of mandible, and which is hard in consistency. On systemic examination, cardiovascular system, respiratory system, per abdomen and central nervous system, there was no abnormality detected. Musculoskeletal system, there was no spine or sternal tenderness, and there were no deformities. Examination of possible flap donor sites. Bilateral lower limbs were normal. Scar of previous split thickness skin graft was present over left lateral thigh. Bilateral lower limb, anterior tibial, posterior tibial, and dorsalis pedis pulsations were felt. Anterior chest was normal. There was no deformities, no scar or sinuses over the chest. My clinical diagnosis is malignant ulcer of left buccal mucosa, most probably squamous cell carcinoma, with clinical staging T4A, N2A, MX is stage 4A. From the management point of view, for the tissue diagnosis, I would like to do the punch biopsy from the most representative or suspicious part of the lesion, not including the necrotic part. And then I would like to get the pen endoscopy done to rule out any other synchronous lesion associated with this lesion. CCT head and neck to be done to know the local regional spread of the disease and for staging, along with the CT thorax to rule out any other metastatic lesion in the lungs. Followed by routine blood investigations and ECG for PAC workup. The CCT head and neck showed ill-defined heterogeneously enhancing thickening involving the left buccal mucosa with ulceration, maximum thickness of approximate 7 mm. Posteriorly, there is loss of fat prints with left masseter muscle. Heterogeneously enhancing ill-defined soft tissue mass is seen involving left masseter, which appears bulky. It measures 6.4 into 4.3 into 5.7 centimeter. This soft mass is seen involving the submandibular gland. It is abutting the adjacent hemimandible with area of erosion along the inner cortex. There are indistinct planes with medial pterygoid muscle also. Few subcentimetric and enlarged 1A and 1B station lymph nodes were seen measuring approximately 10.9 mm at left level 1B station. These CT images, there is a mucosal thickening on the left buccal mucosa. Also, there is a cortical erosion at the coronoid process was also seen on the CT scan. And left infratemporal fossa was free of the disease. My treatment would be wide composite resection, that is wide excision of the buccal mucosa and outer involved skin with 1 centimeter margin, with upper alveolectomy, with posterior segmental mandibulectomy from left lower canine anteriorly to the condyle of mandible posteriorly, with excision of left submandibular gland and lymph nodes, along with left-sided modified radical neck dissection, and followed by reconstruction. My reconstruction plan is, first plan is free anterolateral thigh flap, and the second plan is pectoralis major myocutaneous flap with deltopectoral flap. Thank you.
Dr. Vinay, sir. Dr. Vinay?
Hello. Yeah.
Sir, would you like to ask in history or clinical examination anything you would like to ask him?
So tell me what are the reasons when you will classify a particular case as an inoperative case, when it would be an inop case. How will you look for that?
When there will be a skull base involvement or encasing of the major vasculature in the neck, or there will be a metastasis from the retromolar trigone from the V3 of the V3 branch of trigeminal nerve to the trigeminal nucleus, sir.
What and how do you ascertain that? What did you say about the skull base? How do you see that? Involved in CT scan, how does it appear? You are right in what you answered, that it can be in the skull base, but how do you see it in a CT scan? It is involvement of which particular area that points towards inoperability of a particular case?
Sorry, sir, I don't know that.
In infratemporal fossa. So if infratemporal fossa is involved, and which is obviously, if you see as you go higher up in the retromolar region, it actually, the coronoid process and all that points towards that area. So from there, the disease may track into the infratemporal fossa, and then it becomes inop.
Yes, sir.
Okay, and what are the other reasons? For example, in case of a mandibular involvement, what is the significance of the inferior alveolar nerve involvement? What is the significance? What does it point towards, and is it important?
Yes, sir. Sir, inferior alveolar nerve involvement will lead to the early metastasis to the mandible, which will require segmental mandibulectomy, sir.
Okay, and segmental mandibulectomy. How do you? Is it possible to do frozen section in bone?
No, sir. Frozen section is not done for the bone, sir. Soft tissue margins can be assessed on frozen section, sir.
So how do you assess, and what will be your, if suppose mandible is involved, how do you calculate in a dentate patient involvement? I mean, the margins for the bone. How bone margins are calculated?
Bone margin.
Yes.
So
For example,
taken 1 centimeter from the cortical erosion on the CT anteriorly and both posteriorly, sir.
No, centimeter is not used. And
One-
why?
1
If
teeth,
suppose
sir.
1 centimeter coincides with the middle of a particular tooth, how will you do that? You cannot do. So,
sir, one presiding teeth and one the next teeth anteriorly and posteriorly will be.
So wherever the lesion ends,
Yes, sir.
wherever you calculate that the lesion is up to this point, like you take a 1 centimeter margin, instead of that, from that point, you take 2 teeth away. So that is how you will calculate a bone resection. Okay?
Okay, sir.
Okay. Yes, anybody else would like to ask something?
What is your plan of reconstruction?
Sir, my plan of reconstruction, first plan is, sir, free anterolateral thigh flap, sir.
Can you just show me the figure?
Yes, sir.
No, can you show me the defect once? Or, I mean, if you have a photograph of that particular area.
It's a clinical picture, sir.
Yeah.
What is your defect? Define the defect, Anand.
Ma'am, defect will be around 7 by 7 centimeter of buccal mucosa with around 7 by, sorry, ma'am?
Yes, yes.
Okay.
Proceed.
7 by 6 centimeter of outer skin, upper alveolus, and the mandibulectomy, posterior segmental mandibulectomy from left lower canine up to the condyle. Means condyle will also be removed.
So this will be marginal mandibulectomy you are suggesting, or it will be a total segmental mandibulectomy?
So segmental mandibulectomy.
And alveolar. So how do you describe such defects as? They are known as composite resections.
Yes, sir.
Composite white resection. Okay.
Hello.
So yeah, these are composite bite resections. So
Yes,
what is
yes.
you saying that you're going to reconstruct it using a soft tissue flap, right?
Yes, sir.
Okay. Why not a bone?
Sir, because there will be a cantilever bone can be will fixed anteriorly only, and the skin pedal which will be required to cover the soft tissue defect may not be covered with the fibula because of the smaller skin pedal of the fibula, and the bulk also.
What is your total requirement of skin? Inside you are saying 6 centimeters, 7 centimeters?
Yes, sir.
Right.
Outside 7 centimeter, inside around 7 centimeter, and around 2 centimeter for deepithelization, sir.
Not necessary deepithelization. That depends. If you have a good perforator, you can actually cut. Okay, even if suppose you add 2 centimeters, so that comes to around 16 centimeters of your defect, right?
Yes, sir.
So how much bone do you have over a fibula?
Sir, in these patients, sir, there is a 22 centimeter the bone fibular length, sir, in this patient, sir.
So if you have a 22 centimeter length of fibula, actually you have the same length of skin, isn't it?
Yes.
How do you calculate length of fibula?
So first of all, we mark the head of the fibula and lateral malleolus.
You are leaving 6 centimeters below.
Sorry, sir.
Are you leaving 6 centimeters below?
Yes, sir. Yes, sir.
Correct. And are you leaving something? Above also?
Yes, sir.
Okay. You need not leave. If you want, you can actually harvest the entire head of the fibula as well, but not required. In fibula, usually we leave around 5-6 centimeters above. Why do you leave that much of fibula above?
Sir, because of there is a bifurcation of that common peroneal nerve at around 6 centimeters.
Save the common peroneal nerve, it is still possible to harvest the head. And why do you leave 6 centimeters below? So up in the upper area, in the upper part of the fibula, you can actually harvest the entire fibula if required. If required, not usually. It is not required, so we better leave it like that and don't disturb the nerve. But if suppose you want, you can. Now, what about the lower end, the lateral malleolus? Can you harvest that?
Sir,
can you harvest lower end of fibula?
Sir, it can be harvested with it will require fixation with screws and plates.
It is not possible, dear. If you will take away the lateral malleolus, the ankle joint will become unstable. No, the ankle model forms a part of the ankle. So lower end of fibula is never taken.
Yes, it's not.
That always will have to leave, right?
Yes,
that you will not take. The lateral malleolus you cannot take, but upper head of the fibula you can take. Now you are saying that leaving 6 centimeters above and 6 centimeters below, you are leaving 12 centimeters, which is okay, and still you have 22 centimeters of fibula with you. Now, those 22 centimeters of fibula, if you just take the skin above the fibula, it is 22 centimeters of skin length that you are getting, and you are saying you will fall short of skin. You require only 16 centimeters. So you will not fall short of skin. You may justify not doing a fibula. I'm not debating that, but yes, you can harvest a fibula. Still, you can reconstruct using fibula, and the skin paddle you will have sufficient.
Okay, sir.
Right?
Yes, sir.
But maybe you will not be able to do, give osseointegration. It's of no use because maxilla also doesn't have teeth if you are excising the alveolus. So yes, you can do a soft tissue flap. I'm not against that. But yes, if required, fibula also is possible. Many people will generally use fibula for reconstruction of the mandible and just the skin paddle of the fibula for the rest of the thing. Inside, generally people will not reconstruct the maxilla, but it is possible to reconstruct the maxilla as well. You can remove 2 centimeters of bone in between, convert the entire bone, the upper portion of the bone goes to the, or you can say the distal portion of the bone goes above for the alveolus reconstruction of the maxilla, the lower portion for the mandibular reconstruction, and the skin paddle you can fold or divide, and you can use a fibula also for reconstruction. In that case, you can give, but since the condyle is missing, this fibula you cannot osseointegrate.
Yes.
That one justification you can give for not using fibula.
Yes.
Okay.
Yes.
Anything else anybody would like to ask?
What will you do for the neck? What is the plan in the neck?
Sir, left-sided modified radical neck dissection, sir. From level 1 to level 5.
What type of flap? What flap extension you will give?
Sorry, sir.
For doing the neck resection. Any modification in your incision? line? Ajay, you have already marked it.
Yes, sir.
Okay.
I will extend the
What is
incision by.
this extension? What is this extension?
Sorry, sir.
Does it have any
Have you
name?
Anand, have you marked your flaps?
Sorry, ma'am.
Have you marked your flaps?
Yes, ma'am.
So ALT.
Yes, ma'am.
Would you
What was
like
the
to ask
template?
any?
Madam, please continue. Yeah.
Anybody else would like to ask any questions in the case? Other PGs? Do you have any doubts?
Yes, ma'am. There was one doubt asked by a resident: how to calculate the extent of bone osteotomy in edentulous patients?
Sorry. Hello.
Vinay sir?
Hello, yeah.
Actually, the Anand was telling he will calculate depending on the findings in the CT. Actually, we take the one or two teeth from the lesion.
Correct.
Yes.
Is right.
What is your this thing, sir? In
So, no,
resection,
so in the what our in our hospital, what the way they excise is whatever is appear. I mean, whatever appears wherever you see the lesion, to take the margins,
yes,
like whatever is it may be on CT also. Even if you see on CT, whatever involvement we see, we need to go beyond that. So involvement,
actually
beyond involvement is two teeth. Huh?
sometimes the bone involvement may be less in the center. It will be confined to center, and the lesion will be larger.
No,
So
no.
you would like to take the bone depending on
Only
the
right on
tissue
CT.
lesion,
Yes.
the CT.
On CT. So whatever is available, I mean, visible, clinically, palpation and CT scan finding, whatever is involvement to the bone, the soft tissue involvement is separate. For example, if suppose the lip is involved, or if the gingiva is involved, then definitely they will take the gingiva as the margin. And beyond that, they will take the bone. But if it is like, let's say, the skin is involved or the buccal mucosa is involved and the teeth is involved only up to a particular point, that point they will take. I mean, that has to be free from wherever the bone is free to teeth beyond that. That is how they will calculate.
So in the case of an edentulous patient, how do we go about?
Oh, in the case of an edentulous patient, this problem will not arise. No. See, this problem arises. This problem arises because in a patient who is dentate, you cannot go in between the teeth. So if you take, let's say, 1 centimeters, you may go approximately 1.5 teeth. So between the teeth, you cannot cut. So you will have to go at the base of that teeth, and just beyond the second tooth, you will cut. That is how it is done. In an edentulous patient, you can actually see 1 centimeter and go beyond that. So that's not going to be a problem. In CT scan or anywhere, then you can go, because then you can calculate, or you can see wherever the root is, you can go beyond that. But in an edentulous patient, this problem will not arise.
Okay.
Yeah. Now, one quick
So 1
question.
centimeter.
Yeah, 1 centimeter. Otherwise, the standard is 1 centimeter, or I mean, that is how they will calculate. Or at least if they see the canals, or according to that. One quick question: what is MX in when do you call a particular lesion as MX?
Sir, when we do not know the state, Malignancy, sir. Means metastasis.
Also, when some chemotherapy or something has been given before. All right, if suppose there is a lesion, you have given chemotherapy, and when it is not possible to assess the state of a particular disease, then also you use the term as X. Okay.
Yes, sir.
Here, therapy or radius.
Yeah. Anything else? Otherwise, we can.
Any more questions or options? If no one is having